Very good evening, colleagues. The time is 6:30 p.m. SAST. A very warm welcome to our Intellectus Campus Wednesday evening sessions. My name is Obake Mwatse. I serve as the General Manager of Intellectus Campus Group of Companies. We are a group of training entities that are based in South Africa, Botswana, Zimbabwe, Namibia, and Eswatini. A couple of housekeeping requirements as we proceed with this evening's session. We will be sending out a link for the attendance register. Please refer to the chat for that link. The link would like to issue out in 15-minute intervals. So please complete that via the link. The link will also enable us to circulate the CPD certificates once the session has been completed. So if you do not complete your attendance details via the link, we may not be able to circulate your certificate. So please be mindful of that. Secondly, this is intended to be an interactive session. Please feel free to raise your hand to be recognized. Alternatively, please raise your question, your comment on the chat function, and that will be read out by the members of the Intellectus team, either in the beginning or during the course of the session. A reminder for all colleagues to remain muted unless recognized to be making a contribution. Otherwise, please continue to remain muted throughout the duration of the session. The session is also recorded and also running live on YouTube together with LinkedIn. This evening session, Infection Control, moderated by Dr. Jackie Stone. Dr. Jackie Stone is a Zimbabwean primary care physician with various qualifications, together with having graduated cum laude from the University of Cape Town. Her career includes working on HIV treatment and prevention in the UK, contributing to the introduction of the combination antiviral therapy. She's worked in the Middle East airline industry, together with having worked in Australia. Her focus includes risk-benefit assessments, hypoxia, infectious disease treatment and prevention, and vaccinations. A very good evening, Dr. Jackie Stone.
Thank you very much, Obi. Can you hear me?
Loud and clear.
Excellent. Welcome, everybody, to the second Intellectus Campus session this year. I'll be joined by two panelists. One is Mr. Newton Moyle, who is the Deputy Director Research from the National Institute of Health Research in Zimbabwe, which is affiliated to our Ministry of Health. And he is a microbiologist, a clinical epidemiologist, and he's a PhD fellow at the University of KwaZulu-Natal, focusing on health systems. He teaches microbiology and infection control at Bandura University of Science and Education, and he will join us for the questions. We are waiting for Dr. Hector Carvello to join from Argentina. He's having some connection problems. His WhatsApp is working, but his Zoom is not. So hopefully he will join us by the end of the session, because both of these two panelists know a great deal more about infection control than I do, and I'm probably going to pass lots of questions on to them. So I'm going to start the presentation just to remind you of the housekeeping rules. There may be questions that come up in the chat, which is quite common, that say that people can't hear. You actually have to log into the audio. So what I'd like to start with is to discuss our themes for 2024 in terms of what Intellectus Campus's goals are. So the concept I'd like to introduce is one of constructive controversy. And the advantage of controversies and the biggest benefit of constructive controversy is that it leads to better decision-making and problem-solving. And it protects teams from logistical fallacies and blind spots. And what we don't want is one-way thinking. We want to distinguish the difference between debate and conflict. And the only way to achieve African solutions for African problems is that if we openly discuss them among ourselves. There is no obvious or right solution until you see the full picture.
Because we are closed already, I'm just waiting.
And Pride, can Sorry, I think there was a mute all there, and I'm not sure how much people heard. Did we go through the constructive controversy? Did you hear that, Obi?
Dr. Jackie, if you can please repeat that section. And then just as a request, colleagues, if you can please remain muted for the duration of the session.
Okay, so I'll go back to this the slide. The themes for 2024 for Intellectus Campus are to encourage constructive controversy. And the biggest advantage is that it leads to better decision-making and problem-solving. And we don't want a one-way system. Anybody who has driven around Central Harare will know the nightmare of the one-way systems. So we want to encourage debate. It is not conflict. Two perspectives can give a much better depth of vision. Each eye receives a different signal and a completely different frame. And that is interpreted by your brain to give stereoscopic vision and depth of vision. The reason 3D glasses work is they delay the frame on one eye and they create an illusion of 3D. So we need to learn from that. And I might see it from one perspective and someone else might see it from another. But if we don't feel free in a safe environment to discuss that, then we will never progress. And I want to encourage that theme as we go through this talk. And I absolutely invite everybody on this call to come up with controversial questions, because we need to debate infectious disease. We are African doctors. We know how to manage infection, and we bow to guidelines given to us by places that think an outbreak is 17 people getting sick after a Chinese takeaway, when we have 135,000 cases of malaria in this country every year. So getting back to the constructive controversy, an obvious and right solution may look quite different when you see the fuller picture. And disagreement can be remarkably constructive if you have a receptive mindset and you follow the right approach. You will make better decisions based on good reasons by considering other perspectives and views instead of rejecting them out of hand. And this is not the first time I've shown this slide, but we need African solutions for African problems. And it's time for Africa to stand up and be heard. So the learning objectives of this talk are to understand the chain of infection, to understand the Semmelweis reflex and challenge our own thinking, to understand the portal of entry, which will be the focus of this talk. This is the first of 6 talks. The next talk will be on the 7th of March. And this talk, we are very specifically looking at the portal of entry, and we're going to focus on waterborne diseases, given the situation in the region at the moment. We want people to explore and critically appraise new products. And we need to learn and discuss and debate our experiences in a safe environment. So the chain of infection is fairly well known in public health. There is an infectious agent. Today we will focus on waterborne diseases. There is a reservoir, a portal of exit, a means of transmission, and a portal of entry. And we will discuss how to make a host less susceptible in an entirely different discussion, because that focuses on immunity. So with waterborne diseases, what are the infectious agents? They range from rotavirus, enteroviruses, adenovirus, all the way through to typhoid and cholera and bacterial problems like E. coli, and then again all the way through to Giardia and amoebiasis. What is the reservoir? Well, it's water that is not running generally, and for many of us, it's the 5,000-litre tank that is behind our workplace or our houses. What is the portal of exit? In my house personally, I have a tap that runs through an extensive reverse osmosis filtration system, and that is the tap we drink out of. But I wash my glass in water that has not been through that system, and therefore the portal of exit from a contaminated tank may be the glass that I've washed and poured bottled water or filtered water into it. We need to look at means of transmission, and we will be focusing very much on gloves and on preventing transmission of waterborne diseases. But the big focus today is the portal of entry. So the portal of entry in terms of waterborne diseases is the gastrointestinal system. Later in the presentation, I will be mentioning breaks in the skin and ways that we manage that. But at a later date, we will discuss the other systems. But I think the focus at the moment needs to be on waterborne diseases in the gastrointestinal system. So let's go back to basics. The Centers for Disease Control give guidelines for hand hygiene in healthcare settings. And if we want to break the chain at the portal of entry, hand hygiene is the most basic of things that we need to know. And I actually read through the 52-page document on hand hygiene, and I will almost guarantee you that the only other person who's probably read it on this group is Newton. But it is actually quite an interesting document. And if you read the fine print, there's a lot that we don't know. So this is what happens if you Google how to wash your hands. And I promise you, there's at least 50 of these posters. And I'd like to take you back on that note, because we all know about hand washing and we take it for granted. Anybody that was to not wash their hands after examining a patient or before examining a patient would probably be considered negligent. But the first person who described washing hands was a man called Semmelweis. Ignaz Semmelweis had a very tragic story. And not all heroes wear capes. This one from Hungary wore scrubs, and he is known as the savior of mothers. In 1847 in Vienna, he discovered that infection could be drastically reduced by requiring healthcare workers in obstetric clinics to disinfect their hands. And he proposed hand washing with chlorinated lime solutions. And he demonstrated, well, first of all, he noticed that the doctors' wards had 3 times the mortality of the midwives' wards. Doctors did postmortems and came straight from the postmortem to the delivery ward without washing their hands. Midwives did not. He demonstrated a 9-fold reduction in mortality, 18% to less than 2%, by getting people to wash their hands. But many of his colleagues mocked him and said that a gentleman's hands could not transmit disease. And his opinion conflicted with the scientific and medical opinions of the time. And it wasn't until Pasteur proved the germ theory that people believed it because they didn't understand it at the time, because they hadn't looked at this stuff under microscopy. So what happened to Semmelweis? In 1865, he was put into a mental institution where he died. And this is a picture of his grave. He died aged 47 years old. And this is a picture on the right. There is a picture of a bust of him, which I've actually seen in Australia. He has several hospitals named after him, medical institutions named after him. But unfortunately, he died at 47. He was institutionalized and beaten because he became increasingly outspoken, and that was from 1847 to 1865, so almost 20 years of telling people to wash their hands. They eventually put him in the loony bin, where he was beaten by the guards and died 14 days later from a gangrenous wound on his right hand that was caused by the beating. Basically, he died from sepsis in a mental institution for advocating for doctors to wash their hands. And may his soul rest in peace. So the Semmelweis reflex is defined as when current beliefs trump new knowledge. And the question arises why we want to stick with current beliefs, even when we know new knowledge contradicts it. And the effect is described as the invincible social power of false truths. And I think no time has it ever been more important to recognize this than what we've seen over the last 3 years, because we've had totally contradictory advice from 1 mask, 2 masks, 3 masks. The unvaccinated don't need to mask up, then everybody needs to mask up. And we've had this constant conflicting advice, and everybody follows authority and follows algorithms because they are too afraid to not do so. And eventually, people become so confused and overloaded with information that they just basically give up. So I want to play this YouTube clip for you, and I'm hoping that it'll work, but it's a very, very important clip.
I think what we've learned in Ebola outbreaks is you need to react quickly. You need to go after the virus. You need to stop the chains of transmission. You need to engage with communities very deeply. Community acceptance is hugely important. You need to be coordinated. You need to be coherent. You need to look at the other sectoral impacts, schools and security and economic. So it's essentially many of those same lessons. But the lessons I've learned after so many Ebola outbreaks in my career are: be fast, have no regrets. You must be the first mover. The virus will always get you if you don't move quickly. And you need to be prepared. And I say this, one of the great things in emergency response, and anyone who's involved in emergency response will know this, if you need to be right before you move, you will never win. Perfection is the enemy of the good when it comes to emergency management. Speed trumps perfection. And the problem in society we have at the moment is everyone is afraid of making a mistake. Everyone is afraid of the consequence of error. But the greatest error is not to move. The greatest error is to be paralyzed by the fear of failure. And I think that's the single biggest lesson I've learned in Ebola responses in the past.
So at the moment, I'm having a problem because my screen share is paused. So I'm going to restart it. And I'm sorry about this, but this is what happens when people let me run the technology. So did everybody, Obi, did you manage to hear that loud and clear?
Dr. J, the audio was very clear. It's just we couldn't see the screen, but the audio was very clear from start to finish.
Okay, well, it was the same guy talking the whole way through. And Michael Ryan is one of the technical experts with the WHO. And to be quite honest, I don't know why he's not running it after that speech. But in an outbreak, speed trumps perfection. And the executive director of the World Health Organization, Michael Ryan, said, be fast, have no regrets. If you need to be right before you move, you will never win. Sorry, I just need to put this onto. And the speed trumps perfection is really important, because when it takes 2 years to get something through a regulator and there's an outbreak, then a lot of people are going to die. And it's the frontline doctors and nurses and people who are on this group who actually have to face the sick patients. And to be told to do nothing is not really an option. Trial and error used to be the way that medicine was practiced in the 80s and 90s. And if something didn't work, either you had your dose wrong or you had the wrong diagnosis. So you have to run on a moving platform when it comes to infectious disease. These organisms have doubling times. So we worked it out for a doubling time. You will go from 1 million to 2 million to 4, 8, 16, 32, 64, 128, 254, and you get the picture. Within 72 hours, you go from 1 million to 2 billion organisms. And it's a war between your immune system and the bug. And the later you treat, the sicker the patient will become. And then if a cytokine storm starts, we've all seen it with cerebral malaria. If you get your patient in by the time they've got cerebral malaria, then there's no plan. That person will probably never be normal again. So let's look at what's old and slow in infection control. And the FDA rules for healthcare antiseptics basically states that healthcare workers should continue to use healthcare antiseptic products currently recommended in the professional and national guidelines, and including CDC and HICPAC inflection and consistent with policy. So I sort of fell asleep about halfway through reading this. And I think we need to actually make it more simple and more practical for all of us. So infection control, this is the guideline for health hygiene in healthcare settings. And this is the link to it. We all know about alcohols. The majority of alcohol-based hand antiseptics contain either isopropanol, ethanol, N-propanol, or a combination of 2 or more of these products. Alcohols have excellent germicidal activity in vitro against gram-positive and gram-negative bacteria, including multi-drug-resistant pathogens, Mycobacterium tuberculosis, and various fungi. They are effective against certain enveloped viruses, particularly those who are lipophilic. And the examples are given there. Obviously, infection control is extremely important when dealing with HIV virus. I personally have had a very bad needle stick injury, after which I tested negative, but that was in the 90s, and it was 3 very long months waiting for my negative diagnosis. Sorry?
I'd love to have an ability to trek to remote places and not worry about that back.
Can we mute whoever's talking? Thank you. So if we look at bacterial counts on the hands, in multiple studies, bacterial counts on the hands were determined immediately after using alcohol products, and again 1 to 3 hours later. And there's no question that alcohol-based solutions are more effective than washing hands with plain soap in all studies. But, and there's always a but, the CDC have shown that the efficacy of alcohol-based hand hygiene products is affected by several factors, which includes the type of alcohol used, its concentration, the contact time, the volume of alcohol, and whether the hands are wet when the alcohol is applied. They should be dry. But we do know that applying small volumes of alcohol to the hands is not more effective than washing hands with plain soap and water. And when you watch the COVID sort of lockdown mania, where people were squirting at about 0.5 mils of hand sanitizer onto their hands and rubbing them as they went into the shop, that would have been no more effective than a decent hand wash. So it was basically a waste of time. Too little alcohol is ineffective. 1 mil of alcohol is substantially less effective than 3 mils. And it states in the CDC document that the ideal volume of product to apply to the hands is not known. But if your hands are dry after you've rubbed them together 10 to 15, then you've had an insufficient volume. And alcohol-impregnated towelettes are no better than hand washing. So we all know the problems with alcohol. Anybody who has an open wound who's put alcohol on it or methylated spirits will know all about how much it stings. We know that people with respiratory allergies get worse. We've all seen allergic contact dermatitis over the last 3 years. And these sanitizers and these solutions cannot be applied to the eyes or any mucous membranes because they burn. Chlorhexidine has replaced iodine in a lot of settings because it causes less allergy and it also doesn't stain the skin. So chlorhexidine gluconate, which is a cationic bisbiguanide, was developed in England in the early 1950s. It is minimally soluble in water, but the digluconate form is water soluble. And its antimicrobial activity is because it precipitates cellular contents. But this is something I didn't know until I read all 52 pages of the document, which is that its antimicrobial activity occurs more slowly than that of alcohols. That I did know. What I didn't know is that it is less active against gram-negative bacteria and fungi, and it has minimal activity against TB, and it's not sporicidal. It also has good activity against envelope viruses, but it has substantially less activity against waterborne viruses like adenovirus and enteroviruses, which are not enveloped. It is popular, and certainly the surgical scrub solutions that contain 4% chlorhexidine and 70% alcohol are used extensively in theaters, and it does have substantial residual activity. When used as recommended, it has a very good safety record. It is not absorbed through the skin, but you have to avoid contact with the eyes because it can cause severe conjunctivitis and severe corneal damage. It is also ototoxic, so it cannot be used in ENT if there's surgery involving the inner or middle ear. It may not be involved in direct contact with neurological tissue. And the frequency of skin irritation is concentration dependent, with products containing 4%, which is what we would all use if we were scrubbing for theatre, and it will cause contact dermatitis. Another fact I didn't know is occasional outbreaks of infection have been related to infected batches. So let's look at what is new in infection control that's safe, effective, and avoids antimicrobial resistance. And I've put a link there to last year's discussion on antimicrobial resistance. And one of the things that we're looking at in our laboratory at the moment, and we have been looking at for over 6 weeks, and we gave a presentation on this group, which I will share after this presentation, on the safe and effective use of silver solutions. And that presentation was given by Berg, who is very, very well known in South Africa. And what he demonstrated was the fact that silver has been around for over 5,000 years. It has been around before Chinese writing was invented. 3,000 years of Aviation Medicine. And Hippocrates, father of modern medicine, extensively used silver for infections. So it's not anything new. What happened to it? Well, in World War I, it was extensively used. They used silver leaf products. But in 1928, penicillin was discovered by Andrew Fleming. And in 1940, penicillin was commercialized. And that coincided with 48 different silver products coming off the market. And I am not advocating for the use of silver on its own. A lot of quackery has happened using the term colloidal silver. We should be very specific with silver. We should say that it is either an ionic or a nano solution, or it is a combination of both. We should refer to concentrations in terms of micrograms per mil, and we should define the size of the nanoparticles. And until that is scientifically done, colloidal silver will remain highly unpredictable, because many people make it who have no idea of what they're doing. So we'll call it argentum because a lot of people are uncomfortable with silver. It has two effects. It affects the portal of entry. So if you sanitize everything around you with silver, you know that it will, it basically kills staph at a concentration of 25 parts per million or micrograms per mil. We know in our laboratories and in the Standards Association of Zimbabwe Laboratory that it kills staph, Pseudomonas, and E. coli with a 99.99% efficacy rate within 30 seconds. We have documentation from South Africa, and Vibrio cholera, and it takes about 60 seconds to do that. So one thing that we could do as adjuvant therapy, we could mix it with alcohols because alcohol will dissolve in a water solution. It will dissolve both fats, and it's hydrophobic and hydrophilic. And we could mix it and we could add it as adjuvant therapy. I am not suggesting this is the only thing we use. It also, silver phosphate is the most insoluble compound on the planet. Its solubility coefficient is like 0.000000057, which means that it doesn't dissolve in anything. So when you add silver to phosphate, it will congeal. And the entire DNA and RNA backbone is phosphate. So we've demonstrated scientifically, not we as in Zimbabwe, but we as the medical profession have demonstrated that if you add silver to E. coli, the entire genetic material congeals and it forms a ball. The nucleus is no longer a ball, it's a congealed mess. So if we want to stop the infectious agent from replicating, because it's not the infectious agent that kills you, it's the cytokine storm that follows from unstoppable replication. So uncontrolled replication, whether it's a cancer cell or an infectious agent, will overcome your immune system. And stopping replication is the goal. So that is why we refer to things as bacteriostatic and bactericidal. And bacteriostatic agents work because they stop replication and they allow the immune system to deal with the infectious agents that are there. It's not dissimilar to a war between your white cells and the bug. And the more bug that is there, the more white cells you need. And if you can stop the bug from replicating every 6 hours, then you can get on top of the problem. So I'm going to miss that. In Zimbabwe, silver is registered and has been for some time as an alcohol-free sanitizer. It's been and we all know from burns, anybody who has treated burns with SSD, which is sulfadiazine or flamazine, especially if you've kept it in the fridge, we see how quickly it soothes the pain. And the reason is because it mops up cytokines better than any other agent. So dexamethasone reduces interleukin-6 by 20%. Silver reduces it 5-fold. So silver is 25 times better at reducing inflammation than dexamethasone. And I think that for us as medical practitioners and healthcare workers to discount this substance as adjuvant therapy is bordering on negligent. We are not getting into the argument between allopathic and alternative medicine. We need to integrate solutions and we need to combine solutions, particularly where intracellular pathogens are involved. So in our Avicel and Standards Association of Zimbabwe labs, we know that it kills Staph aureus, Klebsiella, E. coli, Pseudomonas, but it doesn't actually kill Aspergillus. So let's look at what does kill Aspergillus. And when we look at reservoirs, the biofilm is a very good hiding place. You can sterilize your entire solution with your chlorinated solutions, but the bugs will go and hide in the biofilm. And the biofilm lives in reservoirs, which can be lakes, they can be water tanks, anywhere where water is stored. So the other thing that's new, and you can have a look at it, we've got it in Harare at the moment. It will be coming in, hopefully, across the region, and it is being extensively used in the Mediterranean in ships. The other thing I forgot to mention is that silver was adopted by NASA for their space program to replace iodine to sterilize potable water. So if we look at what NASA are doing and the luxury yachts are doing, they're using these two products. And we in the medical world are still using alcohol and chlorhexidine because doctors do suffer from the Semmelweis reflex. They don't like change and they don't like anything new. And particularly the regulators want to get 2 years of data on something before they move. That's fine in a situation where there's no urgency, but when we look at epidemics occurring, we have to stop the bug regulating, and time is the enemy. As Michael Ryan said, speed trumps perfection. So a biofilm disruptor is a non-hazardous shock treatment to kill microbes and prevent biofilms from forming within your aqueous system and ensure lasting and cumulative protection. Oxidair is something that we recently brought in from Pantheon Global Health. It's a biofilm disruptor, and it's essentially a unique advanced synergistic biocide, and it uses technology that comprises a highly hydrophobic, in other words, water-liking polymer chain. And it provides a phenomenally enhanced microbial kill. And I'll be perfectly honest, if Gilbert is on this call, which I hope he is the microbiologist at Avicel, he was really excited when we actually saw it kill and remove Aspergillus, because nothing else does. So this is Oxidair. If you look at a control plate, at 20 minutes of putting normal saline on it, that's what it looks like. If you put Oxidair, if you pre-treat or post-treat it with Oxidair, you will see that there's absolutely no growth. If you were to use a 5,000-liter tank, we're currently running in the lab. If we had a partner over the weekend, I'd have the results of this today. But unfortunately, we did, so we've had a delay. But by tomorrow, I should be able to tell you what a 1 in 5,000 dilution does. What the studies done by the manufacturer, and I don't trust studies done by a manufacturer because it's a conflict of interest, but the studies done by the manufacturers say that you can dilute this to 1 in 8,000 and it will still be effective. We are looking at 5,000-liter tanks here and 1 bottle for a 5,000-liter tank, and therefore we are running it at 1 in 5,000, and we are running head-to-head E. coli against normal saline, against Oxidair, against silver, and against chlorhexidine with 70% alcohol, and it is a 4% solution. Hopefully by the again, we'll be able to show you the results of real-world laboratory experience done in Africa. This is a WhatsApp from the lab. The results at 30 minutes show that there is no recovery in the microorganism in the treated sample, so we can conclusively say that it is effective in stopping microorganisms regrowing. The other thing I wanted to touch on briefly, and I just need to check the time. Obi, can you tell me what the time is? Because I'm on full screen and I can't see.
The time is 19:10. It's 10 past 7.
Okay, so I'll go for another 5 minutes because I want Newton to be able to answer questions. So what's new in wound care? Cuts and breaks in the skin. We are actively involved in a multi-center trial in Africa, looking at the portal of entry being cuts and breaks in the skin. We can break the chain of infection at the portal of entry using wound care as well, hand hygiene, aseptic techniques, but as well as wound care. Bearing in mind that, well, the first thing is, why is it important? Because not controlling infection is extremely expensive, whether we're talking about waterborne diseases or whether we're talking about surgical site infections. And if we look at the US data, a surgical site infection post-Caesar, post-PIN, post any surgical procedure is 89% increase in costs. And those costs are costs that we cannot afford in Africa because they involve prolonged hospital stays and the requirement for excess staff. And we don't have enough staff and we don't have enough beds. The other thing with antimicrobial resistance, we've been very strong in it. We went through a whole presentation on it last year. We need to minimize the need for antibiotics. I have a patient who has recently had the Mercedes-Benz cut for liver surgery, and he got MRSA at the Cleveland Clinic in Abu Dhabi. And they are still trying to contain it. It nearly killed him. And so we know that by 2050, 10 million people will die every year because of antimicrobial resistance. So we're looking at a product called Preventagen, which is an organic polymer, and it is in a solvent that called methylene chloride, which will then evaporate and it leaves an artificial skin. So it replaces the need for dressings. It does sting, but if you put it on a wound that already has had lignocaine, or the patient has had an epidural or is under general anesthetic, you have to put it on once. It lasts for 3 to 5 days. It's water resistant, it's odorless, and you can mobilize your patient early. I've dealt with this on previous presentations. What we do know is in orthopedics, the cumulative pin track infection rate is 27%, whereas when Preventagen was used in a specific study in the US with 60 patients in each arm, they showed that they went from 23% pin track infections to 0% pin track infections. And if you're interested in p-values, the p-value was like 0.0001. So the last thing, PPE, and I'm not sure if Dr. Carvalho is on the call yet. I'll check on my phone in a minute. But this person technically should not get an infection. They are gloved, they are gowned, they are masked, and their eyes are protected by a visor, and even their hair is in a net. So if we're looking at the portal of entry and transmission, this person should not transmit, and this person should not be able to get anything. But if we look at PPE versus prophylaxis, Carvalho's work basically showed that with 1,200 healthcare workers in Argentina, he looked at PPE alone versus PPE with an agent that they were studying for dengue. And when they tried it against coronavirus, what they discovered was that 58% of healthcare workers in full PPE became infected and tested positive, whereas that there was no illness in the group that had both. And the important thing that I have mentioned on this morning's talk is that if I ask you to calculate area, what is more important, the length or the breadth? Away from this. Very often both are required. And in this case, and I'm not sure if Hector is on the call, but in this case, if I ask Hector what he would say. And with that, I would like to advise people to start to learn to think for themselves, know the enemy. It could be Ebola virus, it could be Marburg virus, it could be E. coli, it could be Vibrio, it could be coronavirus, all manner of pathogens. Whatever disease X is, it's not like in Africa, we don't deal with infectious disease all the time. And what we do, just like malaria, is we hit it hard, we hit it early, and we hit it with combination therapy to prevent the development of resistance. And we need to work as a team in Africa, and we need to stay ahead of the pathogens. And we can only do that with constructive controversy. So our current state is not the same as our future state. And to get to our future state, we need analysis, strategy, execution, evaluation, and then we return to analysis, strategy, execution, and evaluation. And we need to talk to each other and on forums like this about what is working in Africa. And I will end it there and open the floor to questions. Obi, can you hear? Or have I've got an unstable connection.
No, it does sound like it's stabilized. It was a bit unstable closer to the end. We can hear you loud and clear now.
Okay. So I would like to invite Newton to give some comments. He is much more experienced in infectious disease than I am. And I'd love to hear his comments on everything, including teaching students to think, which I know he's very passionate about, and including what we do about infection control in Africa. So, Newton, I'd invite you to unmute.
Thank you very much, Jackie. Can you please confirm if you're hearing me?
I can hear you loud and clear. Thank
you very much for the loud and elaborate presentation. It was a great talk. Thank you again, because you have actually explained it very well. The issues around infection control and prevention are becoming quite topical in these days. There was an assumption that healthcare workers, by nature of their training, they know infection, how to prevent infections, but that was not until the COVID pandemic struck. This is what resulted in the need to emphasize on preventing infections. I will come to some of the issues that you talked about with respect to infection prevention and control. As healthcare workers, we tend to take some of these practices that we do not very seriously, because the main challenge with the pathogens that we're dealing with is that we can't see them. And when we can't see them, it is by faith that we are preventing infection. We are preventing infection, and I'm happy because you talked about the need to prevent infection in our healthcare facilities, wherein you touched briefly about issues around hand hygiene. A sad story about Dr. Semmelweis, who passed on because people were not understanding what he was saying. It's a sad story, but very practical and applying very well to our setting. The reason why we look at our hands, if we don't take care of our hands and clean them, they become weapons of mass destruction to our patients as healthcare workers if we are not careful. The reason why there was need to introduce the famous 5 moments of hand hygiene. Before touching a patient, you're supposed to take care of your hands so that they don't become vehicles of infection to our patients. Then before you carry out an aseptic procedure, this one touches mainly the clinicians. You are our heroes who get in contact with our patients. You need to make sure that you clean your hands. Then after contact with body fluids, you are supposed to clean your hands. After touching a patient, you are also supposed to clean your hands so that you make sure that you don't put yourself at risk and others at risk. And after touching the patient surrounding, we are supposed to make sure that we take care of our hands by way of cleaning them. So it is, of course, believed that when you are doing active patient care, the procedure of taking care of our hands and cleaning them is supposed to be done between 3 and 30 times. It's supposed to be repeated. So if you've got some hand rub, you are supposed to do it some hand rub agent. Per hour, you are supposed to use the hand rub agent between 3 to 30 times. That way you can reduce the rates of infections in our healthcare facilities. I also wanted to talk about some enablers to prevent infection in our healthcare facilities. For example, where do we place our hand wash basins? Like, for example, inside every room with a toilet, inside or close to each nursing station, inside dirty utility room, inside dirty linen holding area, inside or close to staff lounge. So I'm talking about this because we are discussing here a very important area, which if we don't take it seriously, it can result in some, I think Dr. Jackie, you indicated about issues around transmission of antimicrobial resistance. So the use of personal protective equipment, like you indicated, Dr. Jackie, where we believe that if we are putting on personal protective equipment, then we are not going to be infected. It has proven that it's not really the case. Use of personal protective equipment is actually the least effective. What we are supposed to make sure is that we are not supposed to allow these pathogens to be existing by way of using those various agents that we talked about, where we need to decontaminate our surfaces, the items that you use for some procedures, they are supposed to be sterilized. That way, we make sure that we are avoiding, we are further reducing the chances of ourselves getting infected. And I also think that I need to comment a little bit about ideal hand washing facility. Something that is not usually taken in much care of, because at times we take it for granted that people know that hand washing facilities, they are supposed to be readily available. And we are supposed to have these hand washing basins that are dedicated for hand washing only. Then they must not have plugs and they must be elbow operated. If we don't take care of these small things, then we will be sure that one day we will, instead of taking care of our patients, we will be patients ourselves. Instead of reading statistics, then we become part of the statistics in terms of healthcare providers who have been infected. I will not talk much about the hand rubs. I think Jackie did a great job. Then I will I will not also, okay, the issues around education is very important, and supervision as healthcare providers are performing their duties, they are supposed to be supervised just to make sure that we address the no-do gap. People know what is supposed to be done, but is it that are they doing what they know it should be done? Then, so we are supposed to monitor compliance to prevent entry at the port of entry. We are supposed to prevent microorganisms from entering into our bodies or the patients themselves. So we are supposed to approach these issues from a multimodal perspective. Let me quickly go on to say we are supposed to continuously monitor and continuously educate people about the need to have these issues addressed so that we prevent the pathogens from entering into our bodies or our patients. Then let me quickly go on to indicate that there are some recommendations on hand hygiene. There are some recommendations which have been provided, but because we are, Dr. Jeki is talking about African solutions to African problems. There are some recommendations which have been, which come from CDC, WHO. At times, if we don't have enough resources, we need to modify, but taking cognizance of the need to make sure that we are not compromising on the need to reduce infection. So this is very important. And I will then come to the last comments. I think, Dr. Jeki, you have addressed it all. I will go on now to some quotations from David Osborne and Ted Gebler, where they were saying, if you do not measure results, you cannot tell success from failure. So we are supposed to measure our results of some interventions that we come up with. So here I'm emphasizing on research and surveillance. We are supposed to make sure that we generate evidence to support what we want to achieve. And if you cannot see success, you cannot reward it. If you cannot reward success, you are probably rewarding failure. If you cannot see success, you cannot learn from it. If you cannot recognize failure, you cannot correct it. And if you cannot demonstrate results, you can win even more than public support. So these are some comments which I just thought, Dr. Jeki, I can just comment on. Thank you very much for the elaborate presentation that you have given us. And I will hand over back to you. Thank you.
Thanks very much, Newton. I see Colleen Aldous is on the call, and we seem to have an enormous number of PhD students going to the University of KwaZulu-Natal. And half of them seem to be going through Professor Ndurukwa, and the other half seem to be going through Professor Aldous. So welcome, Colleen, and I wonder if you want to give us any comments.
Thank you very much for the invitation, Jackie. I really enjoyed your talk. I think an important thing that we've got to keep reiterating to ourselves is, I think you coined the term African solutions for African problems. We know what we are doing on this continent. We are able to think for ourselves. We've been bullied into thinking that the specialists all know what they are doing, and we must do exactly what the specialists are telling us to do, but we actually do know what we are doing. And I would like to, I think I put in the chat there, and I think Newton, you might agree with me, and Professor Ndurukwa too, is don't outsource your thinking anymore. Yes, we've got the excuse to outsource this. We trusted people. We could previously outsource our thinking, just take for granted what the professor said, but we can't anymore. We have to actually look for the truth and move forward for our patients with truth and with real science, not the marketing science that other people have used. Thanks very much.
Thank you, Colleen. As always, you are infinitely more eloquent than everyone else. So thank you for your input in every way, including the help you've given to Zimbabwe over the last 3 years. I'm going through the chat. I can't see. Thank you, Shanae, for your comments that the so-called experts, I mean, I think the word expert has lost all meaning now. I'd be horrified if someone called me an expert because it's almost associated with ivory tower encephalopathy, which is a term that was coined by someone who won't be mentioned in 2021. But I think not outsourcing our thinking is an absolutely brilliant way of putting it. Stand up, Africa, it's your time. You know, if we look at our statistics in Zimbabwe and we compare them to the US statistics, we have 500 times less deaths. So why on earth would we want to do what they're doing? It makes no sense to me. And we defer to the great institutions of Oxford, Cambridge, Harvard, Yale, and I could go on for half an hour. And in fact, we have so many people in Africa who have trained at those great institutions and have come home. And they have first world training with third world experience. I did more chest drains in one night at Grootersdorp Hospital than I did in the next 20 years in England, Dubai. I did one chest drain in 25 years when I worked abroad. So we must appreciate that experience, the best available evidence, and patient choice leads to the best outcomes for patients. Right, with that, if there are no further questions, if anybody has a question, can you please raise your hand? I'm being monitored by Namibians, so we stick to time. They're very Germanic. No further questions. Can I hand over to you, Obi, to close?
So, with pleasure. Thank you very much, Dr. Jackie. Just a reminder, colleagues, we do have a link that's reflected on the chat. If you can please complete your attendance details before you log off, otherwise we won't have your details to circulate your certificate. So if you can please refer to that link. Pride, if you can reshare that link, that would be appreciated. Dr. Jackie, thank you very much. Dr. Newton, thank you very much for the stellar presentation. A reminder to colleagues that the recording for the presentation is available on the Intellectual Campus YouTube channel as well. If you so wish to enjoy a reference from it. With that said, colleagues, once you've completed your attendance register, please feel free to log off. A real pleasure to have had you in our audience this week. We look forward to having you again next week, Wednesday, same time, 6:30 p.m. Have a good evening.
Thank you, Obi. And just to mention next week, because I always forget to do this, next week we will have Dr. Erica Drews presenting, and she will be presenting on the reanalysis of the Women's Health Initiative and looking at hormone replacement and the controversies surrounding it in terms of which hormones do and do not cause cancer. So I'm looking forward to that because I distinctly remember the day when the Women's Health Initiative study was released, and every single woman in Australia that I was seeing promptly came off ART. And the pendulum has swung, and we understand hormone replacement a lot better than we used to. So Erica did a brilliant presentation on chronic fatigue syndrome for those of you who saw it, and I'm very much looking forward to her speaking next week. So I hope to see many of you on the call next week. And with that, I think we should close. It's now 19:35, and I think at 19:45, we need to shut down the registration link and wish everybody a very happy Wednesday evening.